Mr. Song, we can't hear you. Your microphone is off.
Oh, yeah, obviously we need a mic. Okay, orthopedic chapter is, like I said, it's all about fun at work. The surgeon used to say, I'm repeating this again, surgeon used to say, two people, that's you and the surgeon, uh, cannot have more fun in any other job than doing a femur rimming a femur and have this fun at work. The greatest fun one can have is it in the orthopedic surgery. You get to use slap hammer, mallet, saw blade, reamer, drills, uh, uh, intramedullary rodding system, huge plating, all kinds of stuff you can do in the orthopedic surgery. So let's see what's happening here. This picture, this you are seeing people, the staff, the orthopedic surgeon, their assistants, and the surgical technologists, they're all wearing laminar airflow gown. They call it space gown because these people are wearing this type of hood and they're attached to a battery pack which brings in their air from the top using a air fan here on top. You cannot see it, it's inside, and they are attached to a tubing, airway tubing, a huge, big, large diameter tubing, which is attached to the air supply to them. So they're not breathing the air from the environment, or they're not breathing in or out on this surgical site here. The surgical site is free from any airborne particles from these people. These people are all wearing these suits, laminar airflow, and they're getting their flow from the laminar air. And this is how they prevent any type of airborne microorganism to pass inside the joint from these people. We all, have residual microbes in our nasal pathway, in our mouth. Although if you wear the mask is very, very effective, but in order to have a really, really 100% microbes free, pathogen free surgical site, this technique of laminar airflow is being in use for many, many years now. At least 40 years. The laminar airflow has changed its shapes and its dressing area. Hoods used to be very heavy, like you're wearing a dress which is thick and heavy and claustrophobic, and that used to I can feel those thing. I think they used to wear a gown which is almost like 25 pounds of weight to carry. Like this now this light impervious paper gown, light impervious these type of hood solves that problem of wearing heavy laminar airflow gown throughout the procedure, and that kind of restricted their movement back then. But now it is rather light, easy to work and move around, and you have a better, the visors are also wide view, so you don't have any the problem with claustrophobia, and you can hear very well with this gown. You don't have to, before you had to really yell to tell something to your coworker, the room staff, but now it's not that case. Okay, now surgical technologist's job is to wear it's the first one to come in after hand scrub and using aseptic technique with the help of a circulator, wear these gowns first. They're the first one to wear these gowns. Then other team member come one at a time after surgical hand scrub. They will come in and then the surgical tech will help these people to wear these hoods and visors and the gown and gloves at the final stage. So this uh, uh, type of technique allows a very methodical way to prepare the whole team for the surgery. Uh, Total joint surgery requires more than two assistants, someone to hold the leg throughout the procedure, someone to assist directly uh, the surgeon, and another person to hold retractors. So you have more than two assistants, as you can see here, three people, and the surgeon. And then you have surgical technologist. So sometimes we have two surgical technologists. One of them will assist, one of them will hold the leg, and one of them will do the instruments. So the job is divided, and circulating nurse will circulate the room. That is how the laminar airflow room works. Here at the X-ray view box, you are seeing two knees with the arthritic degenerative changes, and they are working on this person's left knee. As you can see, the left knee is draped, leg is draped freely. Means the leg is draped from the toe all the way up to the knee. Is everything is covered, the rest of the body is covered with stereo drape. So what they do in this case, they put many drapes, sheets to cover the below the underneath this leg. Then they will put this impervious stockinette after this leg is prepped with betadine or any other cleaning, other prepping agent, as it is listed in the preference card. So this leg will be prepped from the toes all the way up to the groin area, and then a circulator assistant will put on stereo gloves and hold this leg up, while these assistants will get gowned and gloved and have drapes. They will have drapes. They will put on sheets underneath this leg while the assistant circulator is holding the leg up. And then after they put sheets here at the bottom, sheets at the top, then they will take impervious stockinette to go all the way up to the groin. Then one of the assistant laminar flow gowned assistant will pick up the leg from the circulator, the assisting circulator who is holding the leg with the stereo gloves. Now the assistant will hold the leg up while the surgeon will wrap it with a co-band. This is the co-band. Co-band keeps the impervious stockinette tightly in place. Then they will take this long fenestrated sheet, we call it total knee or extremity drape. That will go through and it will be placed right where the surgical site is need exposure, and it will cover the rest of the torso, head, the anesthesia hood area, and the bottom of all the way up to the bottom of the operating room table. While they do that, the one assistant will take all the suction, uh, pulsovac lavage system, which is the power wash and suction, the Bovi. They'll hook it up on the drape with the holster and clamp it with the drape impervious towel clamp. Surgeon will take a bandage scissor and cut open this impervious stockinette, like as you can see. Surgical tech will take this IO-band drape, as you can see it's on the Mayo stand. They pass this IO-band drape and the bandage scissor so the surgeon can cut the IO-band drape as it is needed to drape this skin part of this open part of this impervious stockinette area. This will be covered with this IO-band drape. The reason the IO-band drapes are used is to have a residual microbes here to keep it below that IO-band drape, below this drape once the drape is in place. So after they do that, this IO-band drape in placement, then everybody will change their gloves. These gloves, they will change the outer gloves. They're wearing 2 gloves now. There are some more gloves here on the Mayo stand. They will wear those gloves. Surgical tech will help them to wear these top gloves. That is when they will start the procedure by cutting open this, in making the incision, officially make the incision here to expose the skin and go through the layers of the skin and subcu and fascia, muscle, then the ligament, capsule to expose the knee, the bone of the tibia, bone of the femur, bone of this patella, and the ligaments like patella tendon ligament, all other ligaments, all other muscles around this area to operate on the tibia, femur, and the patella. Patella will be retracted away from this joint initially, and assistant will hold this. This person is going to go up here above the surgeon and hold the retractor to expose the joint, and this person is going to hold the leg up, flex the thigh by pushing this leg, the foot of the ankle and the foot of the foot, and to bring it up to here and hold it throughout the case or move around as the surgeon requires. Laminar airflow also flows the air through the laminar ventilator system of the room. Air passes in 2 different ways. The air can pass in a laminar airflow room depending on the design of the room. Most of the time, laminar airflow comes from the top and the clean air comes from the top and goes downward. So top area is getting the clean air, and the bottom, that is where the suction is being done, the air comes out from the room. This air circulation system goes throughout the time the laminar airflow is on. This way, the clean air through the HEPA filter, high efficient particle filter or HEPA filter is used to bring out all the air particulate from the room and provide new air in the room, minimizing the air particulate at the joint at this surgical site. Reason this type of meticulous technique of sterile procedure, aseptic technique are designed, created to minimize, to not just minimize, to eliminate all possibilities of joint infection. Having an infection inside the joint uh, can be a catastrophic incident. Joint infection, like osteomyelitis, could be so bad that the patient can go through a shock and have a life-threatening situation if the infection is not controlled very quickly. And having an infection after the total knee joint is done, that means this person's total knee joint implant surgery will fail. Nobody wants to cut the femur off, tibia off, and put implants in, and then fail the joint surgery. That means they have to go in there and take out these implants again, and they have to kill all the microorganisms that is acting and infecting this joint. They have to put the patient in the hospital. The patient is not going to go home for a long period of time uh, to treat this joint infection. Joint infection is life-threatening and limb-threatening. So that is why the laminar airflow system, laminar airflow gowns, and the design of this so meticulous aseptic techniques are being used in the orthopedic total joint cases. So that is what you see here. So our goal is to learn the anatomy of bone, joints, ligaments, and tendons, and we are going to discuss how the joint, how the bone structure works for for a human being, how joint and the bone are structured anatomically, and they have physiological function. And so we will summarize all of these regarding the joint system and the musculoskeletal system. And there are many indications for joint surgery. And the indications, these conditions are usually discussed during the diagnostic procedure. So we are going to learn that. We're going to learn the use of all the orthopedic instruments, how these orthopedic procedures are done, step-by-step orthopedic procedures. We're going to learn about how the bone structures and the management of bone fractures in order to take care of the fractured bone and repair the fractured bones of many different areas. The use of material like cast, how to dress these after the surgical procedures, these wound, how to use cast material, how to use traction material to keep the joint aligned and help the joint to recover from any fracture. So first thing, we're going to see one of the large joint in our body that you all know, the hip joint. Here you're seeing the pelvis. This is the left pelvis of this person in this illustration. And you're seeing right here where my pointer is, that's the sacrum bone and coccyx bone fused together. The sacrum, lumbar vertebra, this material here, and the pelvis, sacroiliac joint. Sacrum and ilium met here at this border called sacroiliac joint. This joint is where symphysis pubis meeting here. This is the symphysis pubis joint. This is where we sit ischial tuberosity, ischium, and then we have the pelvis, lower part of the pelvis, lateral border, where we have this cup called acetabulum cup. Acetabulum cup, where our femur head rotates, circulates, and rotates in many different directions freely in this acetabular cup. Then we have one of the largest bone of the body, femur. And you see the femoral head, then the femoral neck, and then you have the femur, long bone that is going down towards the tibia. This femoral head, femoral neck, and the femur makes this acetabular cup in the pelvis, makes the hip joint. Now you see this shiny white covering, that is the femoral head cartilage. The area here, which has a little wedged area, elevated wedged area, that is the attachment site for many muscles that work the joint. Muscles from this area to here, muscles from this area all the way down is attached here. This area is called greater trochanter, if you remember from the anatomy lecture. Similarly, across from the greater trochanter, across from the femoral neck, there are another similar area called lesser trochanter, where we have muscle coming from all of these area, joint here, and the muscle goes from here to here. So muscles joining area, greater trochanter and lesser trochanter. These muscles, ligaments, make this femoral or hip joint. These muscles, some of them are internal muscles. They allow the hip joint to move around. Some of them are external rotator muscle. They allow the hip muscle to flex, hip to flex, the thigh bone to flex or extend, or tibia or the leg to work in many different directions. So hip joints, the femoral head kind of articulates with the acetabular cup. That is how this joint is working. So the fracture happens around here, the neck of the femur, around in between this area, greater and lesser trochanter, or around here. Many areas in this femur, the fracture can happen. And degenerative process can happen anywhere in this cartilage area of the bone surface, making this joint painful. So when that happens, this components, these head, femoral head, acetabular cup, femur, all of these can be changed with implant. And that implant will help reconstruct this hip joint. When the fracture happens, there are many ways to manage these fracture, as we will see in our joint fracture management study here later. Now let's look at knee joint. Knee joint, as you can see here in this illustration, we all can feel this patella, the button, the kneecap. We all can touch and feel this patella, kneecap. It kind of, you can slide this left or right, up and down a little bit. And then behind that, we have femur, the end of the femur. This is, you saw the femur started at the pelvic end, and this is the end, another end, the distal part of the femur, we call here. The femoral component here is, you are seeing here, this is what the shiny part is, the articular cartilage, the white shiny part that articulates with the tibia. Tibia starts here, proximal part of the tibia, and goes down to the ankle. That's the distal part of the tibia. Tibia has a lateral bone that is called fibula. Fibula articulates with the side of the lateral border of the proximal tibia. Right here, you can see fibula bone. And here it is, the tibia, the proximal part of the tibia goes down towards the ankle. In the middle of this femoral distal part and the tibial proximal part, we have a joint cartilage, C-shaped joint cartilage, as you can see here. There is a C-shaped cartilage on the medial border, C-shaped cartilage at the lateral border. These are called meniscus. This bluish color component that you see, they're called meniscus. Meniscus allows the femur and the tibia to rotate without any friction. Otherwise, the bone surface of tibia and femur will rotate and erode slowly, and that will dystrophy, that will damage the femur and the tibia. To prevent that damage from rubbing against the bone to bone, this meniscus is there. The meniscus kind of form that lining, kind of like a washer, kind of like a lining, like a washer. So that lining prevents the joint erosion. Joint cannot get damaged by that, as long as the meniscus is there. So we will see that the huge group of muscle, quadriceps muscle, coming from the femur area, going over the patella, going downwards towards the tibia, proximal tibia to the midsection of the tibia, through a ligament structure called patellar ligament. This whole ligament is a continuation of the quadriceps muscle attaching the femur to the tibia. This ligament, this muscle structure is really strong. This muscle allows the activity of this knee joint and the femoral joint as well. If this is damaged, a person cannot function the knee joint. There are attachment, that ligament, we know ligaments are attaching bone to bone. We have few ligaments here, very, very important. Lateral border, we have lateral collateral ligament. Medial border, we have medial collateral ligament. If these ligaments are damaged, that will dysfunction this knee joint. The backside, if you go beyond, this, you're going beyond this patella, there is this area is window is made here. This window is not present there, but this window is drawn here in this illustration to show you the back side of the knee. There are ligaments there, two important ligaments. You know it from the athletic point of view. You folks probably have seen in the high school or in the college game, a lot of athletes, football players, they damage this anterior cruciate ligament. And you have heard this term anterior cruciate ligament that these players damage and they get repair for that. And there is also a posterior cruciate ligament. Both of them are very important in managing the joint articulation. Joint articulation is not possible without having the proper anterior and posterior cruciate ligament. So you see the ligaments, important ligaments, 5 of them: anterior cruciate ligament, posterior cruciate ligament, collateral ligament, lateral and medial, and this patellar ligament. All of these together forms the knee joint. Femoral condyle that you see here, that's the distal part of the femur. And tibial proximal end, which is like a surface here covered with meniscus, is called tibial plateau, because it's like a plateau. The top of the bone looks like a plateau. That's why we say femoral condyle and tibial plateau makes the knee joint. So let's see shoulder joint. Shoulder joint, as you know, comprise of the upper girdle of, we call upper extremity girdle, or this area that you see, the clavicle, scapula, makes up the upper extremity girdle. Clavicle is a long bone, slender long bone, attaches to the sternum part, the mediastinum part, the top part of the sternal notch, and the distal part or lateral border, medial border is there, the midline, and the lateral border comes up here above the scapula and joins with the scapula through ligaments. Scapula has hook-like structure, a structure backside of the scapula called acromion, and a front structure which is hanging here, the hook of patella. In between them, we have ligament. Scapula has ligament everywhere. The top part, superior part, we have clavicle and acromion joint, which is combined together with a ligament. And the top part of the anterior and superior posterior part of the acromion is attached with ligament also. Now, scapula's this complex design allows the arm bone, the humerus head to make this shoulder joint. Without this scapula and clavicle, this joint would not be possible. So they're important. So you need to know that the humeral head auriculus in this fossa of the scapula called glenoid fossa. This fossa or depression, as you can see, is kind of like a shaped, and this fossa is called glenoid fossa, where the humeral head articulates. And the articulation is possible because of all these ligament structure, the muscle structure. You see muscle coming from the lateral border of scapula and going through the ligament and through this passage and attaching to the humeral head. These muscles are called rotator cuff muscle and tendon, supraspinatus muscle, as it is the actual name called. There are muscle coming from here and attaching here, infraspinatus muscle. We have posterior, anterior rotator cuff muscle as well. They're not in the picture. These are the sites of this muscle attachment. The bluish color is the bursa. Bursa is a sac. We find bursa on the surface of a articulating bone, joint bone, and bursa has a fluid enclosed sac we call bursa fluid or synovium in the fluid. So that bursa and the fluid in that bursal sac helps to absorb any type of shock or pressure, shapes this articular surface, which is covered with the cartilage, shiny cartilage, which kind of rotates with the glenoid capsule. A glenoid fossa has also a capsule or articular cartilage. So that helps to prevent, that prevents any type of joint damage during the movement. As you know, as I told you, if we have exposed joint without cartilage, then the bone is rubbing against bone, and that will cause erosion and damage to the bone, which is the process of degenerative arthritis. During degenerative arthritis, patient slowly damages the cartilage, and then the bone is rubbing against the bone and further damaging the bone surface, causing a painful joint. That is why these joints, shoulder joints, hip joints, knee joints, require replacement or reconstruction surgery so that the patient don't have pain from the joint rotation. So shoulder joint, we have to remember these components: rotator cuff, clavicle, acromion, anterior superior border of the scapula, glenoid fossa, bursa, and labrium is also a factor there, which kind of sits at the border of glenoid capsule. Attachment for many ligaments and muscle structure there. So this is our shoulder joint. Ankle joint, it's complex because it has many bones in it. If we look at this picture, this is our distal part of tibia. The proximal end, we have knee joint. Distal end, we have ankle joint. And this is our distal part of fibula, the lateral bone that comes along the border of tibia. These distal tibia attaches to this talus bone and forming this joint here that you see here where my marker pointer is, called talotibial joint or tibial talus joint, ankle joint, you can say. So tibia attaches to this type of bone here called talus. This is the illustration for talus bone right here. You see, this is the area for the tibia to attach with the talus bone. Now, fibula attaches to the side of the talus with the ligament. These joints are enforced. Ligament comes from the medial border, lateral border, they all attaches to this area to make the ankle joint. So that's talus only, the top part of the ankle. The ankle forms with the talus. There is a bone that is the calcaneus bone. We all feel this calcaneus bone. That is the heel bone. Heel bone is called calcaneus. As you can see, calcaneus is a kind of odd-looking bone. Tip is what we feel at the bottom of heel of our ankle, and the top part is attached to the bottom part, inferior part of the talus. The elongated part is attached to many other bones. There are 1, 2, 3, 4 cube-looking bones. There are a circular type of ring-looking bone right here called navicular. This navicular and this cube-looking bone, cuboid or cuneiform, and the calcaneus and the talus forms this proximal part of the ankle joint. This is proximal part of the ankle joint. Superior part of the ankle joint is the tibia and talus and fibula. Ankles, the foot joint, then we have metatarsals, 5 of these bones, metatarsals. These long, slender bones that we can all feel, metatarsals. Then we have phalanges, the distal slender bones. We have proximal phalanges and medial phalanges and distal phalanges, which is the toes. We feel these distal phalanges, the toe bone, and that makes up the foot. Talus, calcaneus, cuboid, cuneiforms, navicular, metatarsal, proximal, distal, and medial phalanges. All of these bones make up the foot. So ankle joint, as you can see, is complex. Most of the ankle fracture happens here, this tip of the tibia. You see the tip of the tibia is like a little elongated piece here hanging from the tibia. That's called medial malleolus. Medial malleolus is attached to this talus bone. Lateral border, lateral end of the fibula also has little spear-headed peaks called lateral malleolus. As you see, these two tip, lateral malleolus and medial malleolus, are so narrow and so slender, and those two areas fractures frequently, causing ankle fractures. So when we have fracture of this medial malleolus, we call it medial malleolar fracture. Fracture of the lateral malleolus, we call it lateral malleolar fracture. If we have fracture of both, then we call bilateral malleolar fracture. Fibula can also fracture here at the shaft. Tibia can also fracture here at this area anywhere, at the shaft area. So those, depending on where the fracture is, surgeon decides fracture management technique. We have to put plates, screws to reduce this fracture, to fix this fracture. Sometimes we can use external fixator, and sometimes we need to put internal fixator. Internal fixator sits at the along the edge of the bone, which is inside the bone joint, or inside the muscle and ligament. External fixator sits outside of the skin and attaches to the bone through pins or through K-wires, hap rods, or many different other things you're going to see through the fracture management area. Now, the wrist and the hand joint. Wrist and the hand comprises with 3 bones called scaphoid, lunate, and triquetrum. And there is a tiny bone sits at the top of triquetrum, is pisiform. Scaphoid is the thumb side. Right here is the thumb. And thumb side is also the radial side. You are going to see why we call it radial side. And the outside edge or the lateral edge, which is this small index finger, small finger, which is the ulnar side. So capitate is another bone. It sits at the below the scaphoid. Hamate is another bone which sits below the lunate and triquetrum. And there is a trapezoid bone and trapezium bone that is attached to this index finger, top part of the index finger and thumb. Then we have metacarpal bones, 5 of them you see here, and proximal phalanges, medial phalanges, and distal phalanges. So this makes up the wrist and hand joint. Fracture happens anywhere in this area. So hand and wrist fractures are complex, and most of the fractures are fixated or reduced and internally fixed with K-wires. K-wire you see widely used in the management of hand and wrist fracture. So the top part of the scaphoid and lunate and triquetrum, we have the bone coming from, we're going to see next, elbow. Elbow, we have the bone coming from the distal part of the humor. Distal part of the humerus is the humeral condyle, where elbow joint forms. Humeral condyle has depression area where 2 bone from the hand attaches. Radial, remember I told you the radial side? So the radial bone, and we told you about the ulnar side, ulnar bone. And radial bone is the lateral border. It's outside edge of our hand. Ulnar bone sits at the medial border, close to our body. So medial, ulnar, and lateral, radial. We have to remember that. And you can orient that to your own body. That is the really uniqueness of these joints, that you can really feel and play with these joints in your own body. You can turn your hand where your thumb is gonna point way from the body. That's the normal anatomical locations of our body. And now when you do that, pointing outside of the body, straight outside of the body, you're seeing the radial bone. You can touch and feel all toward the side of the thumb and the border that creates the area all the way up to the elbow. That's the radial bone. You could feel the ulnar part of the body away from the radius. You can feel that is the border of the medial border of the hand. You can feel both bones in your body. You can feel the elbow, the humeral condyle. You can feel the humeral head at the shoulder area. You can feel those wrist bone attaching to the radius and ulnar. Like here you saw. Let's go back where the radial, now that you have seen radius, radial bone and ulnar bone, now you know radial is attaching here at the scaphoid, humor is attaching to lunate and trichotrum area, the uh, medial area. So you can orient your own body and find these bones. You can touch them, starting from the scaphoid, lunate. You can go side to side, middle, lateral to midline, and you can find these bones there. You can feel the metacarpal bone. And all of these bones that you can locate in your own body gives you a running open book test. You can take your own hand, your own body's own structure, these bones, and you can feel them and you can locate them, so that way you can also answer questions. And during the surgery, you have a thorough knowledge where the bones are located, and you would know what to expect, what is the procedure the surgeon is doing. That way you can anticipate and assist the surgeon properly. If you don't know where these bones are located, if you don't know the anatomical structure, it is difficult to prepare and get ready for orthopedic preparations. You will not know what type of retractor to place. You would not know what type of suture material you need for these ligaments and the muscle and the tendons. You would not know even how to drape if you don't know what joint you're working, how the joint articulates. So many things, the implants, what type of reamer do you need, what type of saw blade, drills you need, you are not gonna know until you know your anatomical structure of the skeletal. So that is why bone structure, the skeletal upper and lower skeletal structure, you have to really invest a lot of time to memorize them. This is all about visual memory. So you can look at the illustration and memorize them so that you know what is happening in that particular surgical procedure. It helps with your preparation for the surgical technique. So radial head articulates with the humeral condyle, and radial head also articulates with the ulnar. Ulnar articulates with the humeral condyle, and the area where all these muscle attaches are known as these fossils. Lateral epicondyle. Epicondyle is just a little elevated area where muscle and tendon and ligament attaches. Medial epicondyle. These two areas frequently breaks. That is why we need to know the medial epicondyle and these areas usually breaks. So we need to know where these areas are located. So trochlea is the area right here you see, that is the attachment for muscles and tendons and ligaments also to make the elbow moves. Radius, ulnar, humeral component to move. Bursa synovium is shown here. That is the cartilage covering. You have cartilage everywhere in the surface area. Cartilage is usually located where the bone rotates to each other. So cartilaginous surface is there, and on top of the cartilaginous surface, we have synovium, fluid, and the synovium fluid is enclosed in the bursa sac. So this area also inflamed routinely, causing synovitis and bursitis, and you get a surgery called bursitis, bursectomy of the elbow joint. Very quick surgery to really get a good relief from excruciating pain. Now, ligament uh, that is attached like kind of like a circular, they are helping the radial bone and ulnar bone to kind of rotate. Ulnar bone has a tuberosity or attachment site for many muscles. Radial bone also has a tuberosity or attachment for many muscles and tendons. So these makes up the radius joint, ulnar joint, humeral joint, and primarily the elbow joint. Now let's see. Now it's a good place to stop for a little okay, the terminology that we need to learn regarding the joint and the skeletal muscle are listed here. Abduction or abduction. AB stands for way. AD stands for towards. Towards what? Towards midline. Way from the midline. Midline is our baseline in our body, and way from midline would be abduction of any limb. Like when you are picking up your hand and you're moving it away from the body, you're like moving it like this, that is abduction or abduction. You could do that with your leg also. When you're standing, bring two foot close to each other, toes and the heel almost touching each other, and then take one of them, maybe your right leg, ankle, move it away to the side. When you're doing that, you are moving it away from the midline. That's abduction. You can do that to your hip, to your shoulder, abduction. Now, when you're doing the opposite of abduction, that is adduction, adduction. Why do you have to know that? Because time to time when you're assisting the surgeon in a shoulder surgery or knee surgery or hip surgery, the surgeon will request you, will give you direction. Okay, now give me some abduction of the hip. And this will, when they do abduction of the hip, this will open up certain joint area that you will notice, the internal area. If you're doing adduction of the knee, then you're opening the lateral part of the knee joint. So you need to know abduction and adduction, adduction. Arthritis is very simple. Arthro means joint. Itis is inflammation. So joint inflammation. Arthrotomy is a joint. Arthro means joint, and otomy means incision into the bone joint. Articulation, it's just the place where joint articulate, place where two bone articulate to each other, so move around each other. Atrophy is absence of trophy. So that means wasting away anything, muscle, ligament, or joint, atrophy. Avascular necrosis. So vascular is where you have vessels bringing in blood. Avascular mean the vessels are not functioning, so no blood is coming. And when no blood is coming to any area, that area will die. And that is simply called necrosis, destruction. When it is osteonecrosis, then we're talking destruction of bone tissue due to not having a blood flow. When the blood is not bringing in oxygen and nutrients to the area, that area will destroy. Bone reduction. When we have joint or bone fracture, that means the bone is fractured away from each other. Two end the fractured area separated. Now reduction is putting the bone, fractured bone, back together, back to the alignment. So simply put, fractured bones are restored, or fractured bones are restored by holding it together, or by clamping it together, or by using fixation. By using fixation, you can hold the fractured bone together, back together. That is called bone reduction. Bursa, we talked about, this is the sac around that lining on top of the cartilage, which holds the synovial fluid. Synovial fluid is a viscid liquid, almost transparent. It kind of helps the joint moisture. It maintains the moisture of the joint surface. Bursa. Coaxa, valga. Coaxa simply means outward, turning something outward. Like you take a hand, or just take a ankle, for example. You are laying down on the floor with face up to the ceiling, and your toes, both toes, large toes, are facing up towards the ceiling. Now in that position, if you slowly turn your large toes towards the wall, to the left, to the right. So your left large toe now is turning, slowly rotating towards the left wall, and right toe is large toe is rotating towards the right wall. In that situation, you are turning it outward. Your joint, hip joint, your knee joint is all turning outward. It's called coaxa valga. Valga means outward turning of a hip joint or anything, knee joint, ankle joint, whatever you're doing. Coaxa vera, in the other hand, means turning it inward. Now you got it all outside, your toes are facing outside. Now slowly bring it in towards midline, and try to even move it further than midline towards your body. Rotate it internally. Then you're getting coaxa vera. So you can do these things on your own body. Looking at this picture, it shows how the coaxa vera and valga looks like. Here in this infant, we have this. We have the foot turned towards midline. That's coaxa vera. When it is turned outward, that is coaxa valga. So this is a congenital anomaly and it can be fixed. It's simply called club foot or talipes equinovarus. Talipes is this angle here, the foot angle, knee, foot, ankle angle, and varus is turned inward. Malunion, simply put, union of fracture in a bad position or in a wrong position, malunion. So when a fracture is managed or not managed properly, then the fracture will heal on its own and it'll get healed, joined together, unionized together in a wrong area. That is going to have then we're going to tell malunion took place. Delayed union, when the healing of this bone is delayed, basically. Non-union, when the fractured bone is missing a bone piece or bone fragment and cannot unionize, cannot heal. So then we have non-union, failure of fractured bones to join together, unite. Osteoarthritis, osteo again is joint, inflammation of the joint. Osteogenesis is the growth and origin and development of bone tissue. This starts from the embryogenic tissue and then differentiate into bone tissue. Then it forms the bone marrow, the red marrow, white marrow, all the bone marrows, the bone cells, and slowly the bone cells develop into a full-blown bone and joint, and that is this growth and developmental process is known as osteogenesis, where bone cell grows and develops. Osteomyelitis, when you have infection, inflammation of a bone joint with bacteria or anything else, or microorganism, pathogenic. So inflammation of joint osteomyelitis or bone osteomyelitis is a bad news. Osteomyelitis of bone or joint could cause septicemia, which is when the body blood system carries infectious disease causing microorganism throughout the body. So the infection kind of goes, blood goes everywhere in the body. So that means body, all areas got infected. That is a life-threatening shock. If not treated, if not controlled, the infection, people die within 2 to 3 days. So osteomyelitis can cause septicemia and people can die. And osteomyelitis can destroy the joint and the bone, and that bone and the joint would be destroyed in the process, and you're not going to have, you may have a patient with limb-threatening osteomyelitis. That is why these are the cause why we use laminar flow, why we are very, very skeptic about draping procedure, prepping procedure. Any doubt we have or any chance of break in technique, we take it very seriously in orthopedic surgery. Everybody is very honest, knowing that their honesty will save a life and save a limb, knowing that they form a conscientious mind. That conscientious mind always helps to prevent osteomyelitis while they're doing any orthopedic surgery. Osteoporosis, this is when bone start to deteriorate because of calcium problem. Bone has calcium, and this calcium, this mineral, causes the bone to form, makes the bone harder. When this calcium is less, the bone becomes soft. And when you have soft bone, it erodes and slowly destroys. That's osteoporosis. That is a genetic disorder also. Osteotomy, when you are cutting a bone, surgical cutting of a bone. You take a osteotome and a mallet, you cut a bone, that's osteotomy. So osteotomy, we do during the surgery of repair of any bone. Talipes equinovarus, that you've seen when the foot turn inward, we call it club foot. Union, when bone heals and it maintains functional articulation, functional joint movement. We call it union of a bone. Especially it's a fracture union. Here, we're going to need the pointer again. So go to this. Here you are seeing a knee scope on this side, on the left side, is being performed to make diagnosis, treatment of any disorder in this knee. Here you're seeing an example of free draping the leg. Here, the leg is prepped all the way up to the toe with the prep solution. Then the leg, the toe, and the leg all the way up to the mid-calf area is covered, wrapped with a stockinette, impervious stero stockinette, and impervious, non-impervious stero coband. This allows this assistant to hold the toe, ankle, leg, anywhere in this area, because this area is still sterile, covered with sterile stockinette and coband. And extremity drape has been placed on this knee joint, covering the torso and the bottom of the operating room table, all the way up to the floor. We have a Mayo stand full of arthroscopic instruments. We are seeing surgeon holding a camera, a telescope into the joint and looking at the knee joint for any type of diagnosis and treatment. Camera cord is going down. This is the black cord, and this is the light cord. Irrigation is going through this tubing here, transparent tubing, so you cannot see, but the clip is right here. So irrigation allows the joint to inflate, and surgeon can then look inside the joint. He can inspect the joint cartilage, the meniscus, joint ligament, bone surface, condyle, the corners of the bone, the edges of the bone, they can really look through the area of the whole total knee joint. And if there is any defect, they can also treat that using arthroscopic shaver to shave the meniscus, arthroscopic grasper, and arthroscopic cutter. They can remove the damaged meniscus. They can repair the ACL ligament using graft material and suture material, screws, and uh, washers. They have many techniques that they can do to repair this knee joint with the use of arthroscopic technique, knee arthroscopy. That is the basic knee arthroscope for diagnosis, but you can add surgeries for treatment through this knee arthroscope. Here on the right side, you see open procedure. This is a closed procedure through the scope. This is an open procedure where the ankle is fractured. And now the surgeon has opened the ankle. The retractor is placed. Assistant is holding the retractor anteriorly, holding the tibial muscle, ligament, and capsule up, exposing this is the fibula. This is the lateral edge of the fibula. This area, the surface area, is talus. The fibular lateral malleolar bone. Right here, you can feel. Right here, this area, elevated area. This area where my pointer is, that's the tip of the heel, the calcanean tip. Fracture is here. You can see if you look at it very closely, like if I do it this, then if you look at the area right where my hand cursor is, that is the area, that border that is fractured. Now it is reduced with the plate and the bone plate holding clamp. This clamp is holding the bone tightly in place, reducing the fracture. That is the inside part of the edge of the bone clamp. This is the outer edge. Now, orthopedic surgeon is inserting screws to make this an internal fixation. This is called open reduction internal fixation of an ankle, or ORIF of an ankle. So they will, we will go through this process again. They will drill the screw hole, put in depth gauge to measure the length of the screws. Sometimes they tap to put cut the bone hole to allow the screw to be placed, and then they use screwdriver and the screws to insert screws. Once the screws are in place, this clamp will come up, they will irrigate the wound, and they will close the layers of this wound with suture of their choice. And they'll put dressing on, and they'll put a cast padding in order to keep this ankle immobilized for at least 6 weeks. This fracture will heal in about 6 weeks, and after 6 weeks, the dressing will be off, and the person will be able to stand on it and put weight on this leg and ankle like before. So that is a ankle fracture management technique is shown here. So orthopedic surgeon who are trained to do this procedure by using many different techniques. They can fix, restore the joint. Bone musculoskeletal system has many functions. Not only it gives the shape and the provide the support stability, it also protects organs inside. And bone also sends and makes nutrients for the body, for the blood. And it is a vital part of our body. So musculoskeletal system allows us to function properly, walk properly, survive. So without musculoskeletal system or broken musculoskeletal system, person can become disabled. So that is why we need to have many type of orthopedic surgery in order to restore the body's supporting structure and function. Bones, cartilage, joints, ligaments, muscles, and tendons. As you can see, all of them are present in this illustration. This is a knee joint we just discussed. We have bones here, femoral bone, femoral distal end, tibial bone, fibular bone, cartilage, which is around surrounding the joint, this area, and also has ligaments, which you are seeing here, holding the bone together, muscle, which is attached here, working as a functional supporting system, tendons, which is the end of the muscle when it becomes tendon and it attaches to the bone or ligament or the joint area. So together, we get the supporting structure for our body. So we have 206 bones, one plus or minus. Sometimes we have one extra bone like pisiform or not. Sometimes usually we have 206 bones that makes up our bone structure. So bone structure has axial skeleton, skull, vertebra, right here you see, ribs bone, sternum bone, appendicular skeletal, skeletals of the extremities, leg, and the hand and the arm. So these bones, it can fracture any place and degenerate anywhere. And so the orthopedic surgeon, they are expert in fixing these bony structures. Some orthopedic surgeons, they even specialize into some special areas, like some only work on the vertebra, their spine surgeon. Some work on the hip and knee, their joint surgeon. Some work on the upper extremities, the hand and arm and shoulder surgeon. Some works inside the joint of shoulder and knee. Their sports medicine surgeon. They work with athletes who has a frequent injury inside the knee joint and the shoulder joint. So you see, there are subspecialization in orthopedic surgery because these areas are complex and they have complicated structure. So it requires someone to go through extra uh, schooling, extra graduate program, become a fellow for these specialty areas. Orthopedic surgeon, uh, regular time they spend on a standard basis, about 12 years for training, including 12 years of training after undergraduate study. So a lot of times they spend learning about the orthopedic surgery. Then they become a orthopedic specialized surgeon. So you are dealing with a person who's working with you as a surgeon, has a long academic background and experience. So they're very, very respected people in their own field. Bone can be classified as long, short, flat, and irregular. Long bones are like femur, tibia, fibula, humerus, radius, and ulnar. The thigh bone and the leg bone and the elbow and arm and hand bone. So that is our long bone you can find over there. Usually in these places, femur, tibia, fibula, humerus, radius, and ulnar. Over the ankle joint or hand joint, we have short bones like carpals and tarsals. The skull, the cranial bone, they are made with flat bones. Ilium, sternum, ribs, scapula, they're all kind of slender, flat bones. Vertebral structure, on the other hand, as you can see, made with small, irregular bone, like vertebra itself, sacrum, coccyx, and mandible. These are structures they made with irregular, small bone. So you see the bone has many different types of shapes and they have many different designs that allows us to have a functional daily life. So types of bone. Bone starts with cancellous layer. Cancellous means soft, spongy layer. That is the inner layer around here. You see spongy area. It looks like sponge. That's the inside layer. And it has red bone marrow and yellow bone marrow also. That's the inner part of the area. That is what grows first. And then we have the outer layer grows with additional calcium deposits, makes this layer, because of hard calcium, this layer becomes compact and hard, like we call it cortical. That's the outer layer. And that has connective tissues in it. Connective tissue connects two ends, connects one end to the other end. Connective tissue is everywhere in our body. Without connective tissue, we wouldn't be able to function. So that is when we work on the cortical surface of the bone, we have a technique. And when we work in the cancellous area of the bone, we have a different types of technique and different types of screws and plating technique. So surgeon, they learn how to deal with cortical bone and cancellous bone together in order to manage a fracture, in order to reconstruct a joint. Now, when we see the structure of a long shafted bone, like the one here, femur, the longest bone of our body, large bone. It's a very, very large bone. As you can see, inside of the femur, the internal part, which is the spongy part, cancellous part, which grows first. Magnifying view shows that this bone, this inner side, has yellow bone marrow filled in that little gap created inside. The internal bone has this yellow and red bone marrow structure filled in this canal. We call it intramedullary cavity. Intramedullary cavity is not empty. It is filled with yellow bone marrow and red bone marrow. Yellow and red bone marrow is a very, very functional tissue for our body's development and growth process. If we don't have yellow bone marrow and red bone marrow, our tissue, like any cell that needs to grow, will stop growing. So yellow bone marrow has the genetic material to grow, to start the process of growing many different types of tissue. Yellow bone marrow provides the information to the cell to locate and go to the targeted area and become that tissue. Like yellow bone marrow, when sends the cell through the blood supply, and it is connected to the blood supply, as you can see here, sends out through the blood supply to maybe to the heart, and it can tell that cell to become heart muscle. So that can grow and become heart muscle. It can go to the toes and it can make the toe bone. So during our growth and development process, this yellow bone marrow is super active. And during our lifespan, yellow bone marrow continues to sends out differentiating structure to become that targeted organ or targeted structure in our body. So this medullary cavity of long bone is important for our body's function, as you can see. So red bone marrow, that goes and circulates in the blood and makes many different types of blood cells, red blood cells, white blood cells, platelets, many different things that is required for our body's function. Inside this cavity, there is a lining of spongy bones then. That spongy bone looks like this, spongy, and they have gaps in between these bone cells. The bone cells, individual bone cells form a line together, like here you can see bone cells. Here, these bone cells are compact. They're touching each other. Here, these bone cells are separated within a gap, created a lot of gaps. That is why it's soft and spongy. Here, it is hard and cortical. There is a lining on the cortical bone. That is called periosteum. Peri means above or surrounding. Peri means basically surrounding. So this osteum or layer of membrane surrounds the compact bone. That's periosteum. Periosteum brings in blood vessels from outside. And the blood vessels brings in oxygen and nutrients for the bone to grow, and also takes out the bone cell or blood cell that comes out from this medullary cavity of yellow and red bone marrow. So these arteries, which is located in the periosteum, goes through these channels of capillary, as you can see, all the way up to the medullary cavity. So periosteum has vessels circulating over the bone through and out from the medullary cavity, from the spongy part of the bone. So structure of bone, as you can see, has many smaller and very functional components. We are not going to really learn very details about the structure, but this is a short briefing of the structure of our long bone. Proximal epiphysis. This is the proximal area of the bone. Distal epiphysis is the distal end of the bone. Proximal is the proximal end of the bone, and distal is the distal shaft of this bone, which is tibia. In between the length of the bone, the shaft is also called diaphysis. So proximal epiphysis, diaphysis, distal epiphysis. Structure of long bone. Fracture management. When we have a fracture like this on the tibia, it can be reduced and we can fix the fracture, manage the fracture, reduce the fracture by doing open reduction surgery, ORIF, or closed reduction. Closed reduction is when we have a simple fracture like this, not open. Here we have a compound fracture and the bone fragment is sticking outside of the skin. This is the skin edge. Bone is sticking outside. This is an open fracture. This is a closed fracture or simple fracture. Closed fracture can be managed without cutting open the skin, without opening the joint, not the joint, the fractured area. That can be managed with this type of cast padding. Splint, external fixator, we can use to heal this type of fracture, put it together, this type of fracture. This type of fracture requires plating and screws, mostly. So fracture can be managed two ways: closed reduction or open reduction. Fracture management process goes through few steps. First, when a fracture happened, then we see it becomes swell fracture site. Why? Because during this healing process, blood vessels bringing in a lot of components to blood vessels, and we have hematoma. That is the inflammatory steps of the natural healing process of our body. Hematoma and this swelling of excessive blood caused by this fracture triggers the response to bring in material to heal this area through the blood. So these blood component comes in and starts the inflammatory process of forming soft callus, cellular proliferation, and osteocytosis. So what happened? This soft callus formation starts, and then this becomes ossified, means immunized. The cells kind of get together and kind of becomes one in this process. Cells are unionizing, kind of joining together. That is when we find hard callus formation. Then excessive bone kind of strips off, and the body absorbs that. Becomes the remodeling process to heal the bone fracture, and now we have a ossified, healed, unionized bone at the end result. So we go through inflammation, cellular proliferation, callus formation, ossification, and remodeling. That is the natural fracture healing process of any bone. And if you don't do anything to any fractured bone, this will heal. But the problem with this type of healing is the bony end, if it is not reduced properly, aligned properly, then we have a malunion. We will have a crooked union, and the person will not be able to function with that type of crooked malunion of a fractured natural healing process. That is why orthopedic surgeon needs to align the end of these two fractured bone in proper process of fixation. So fixation is a process of reducing the end of two fractured element. Cartilage. We talked about that. Cartilage helps the joint to move around, articulate. Here you see a joint of knee. This is a femur, distal end of the femur with this shiny edge to it is the cartilage. It's smooth, firm, and compressible connective tissue forms here during the growth. This is the lateral meniscus. Medial meniscus is a type of cartilage. Here inside the patella, we also have cartilage. These cartilages kind of rotates, slides, glides, moves past each other. Because of this nature of this cushioning end of the articulating bone allows the joint to stay healthy for a long period of time. Fluid in there, enclosed in the sac of bursa, we call it synovial fluid, that brings in nutrition for this area. So this is where a normal, healthy joint moves around, functions, when all of these components work together. Cartilage, when it is gone, the degenerative process starts. Over the edge, the cartilage slowly erodes away. When people has arthritis, genetic problem of connective tissue disorder, these cartilage, which is a connective tissue, they breaks down, they atrophy. When the cartilage atrophied, what we have, the bone and the bone rubbing against each other. As you know, the bone is rough. If we have two rough edges rubbing against each other, slowly they will break away. That is when degenerative arthritis is active in full phase, causing a lot of pain and suffering, and also dysfunctional status of any person. It becomes so dysfunctional, the person usually becomes confined, becomes bed-bound, or confined in a bed 24/7. Some people suffer for months, years before they can repair, and they can finally decide to go or get a treatment to reconstruct these joints with synthetic cartilage, synthetic bone, with bone joint implant. That is how the total knee joint implant reconstruction surgery redesigns, recreates, reconstruct these joints, like knee joint, hip joint, shoulder joint. Orthopedic surgery, as you can see, a lot of information, and you will slowly comprehend everything. Let's see, joint. When we have this type of damage to the articular cartilage that you see, then the range of motion, what we call the motion of this joint, becomes non-functional. Patient will move this joint and the femur will get caught in the tibia. It can lock while they're walking, and then that will require a surgery to repair this area. Now, joints has many different types of movement. Hip joint has a ball and a socket, the cup, hip socket or acetabular. So we have a hip joint here, ball and socket joint. Shoulder also has the same type of component, ball and socket. So shoulder and hip, ball and socket joint. Elbow, knee, right here you see elbow, the humerus end and the ulnar bone kind of has this type of hinge joint, moves in direction like this. Wrist has a component which kind of rotates in different directions, all different directions, condyloid joint. Then the thumb rotates in this type of saddle-like fashion. So we call it saddle joint. So many different types of joints and their motions. Ligaments, medial collateral and lateral collateral, and ACL, anterior cruciate ligament, posterior cruciate ligament. Important ligaments that host the tibia and femur, fibula together in this knee joint. Muscles, they are the functional part of the skeletal. Here you can see all of these muscles. Pectoralis muscle in our chest, largest broad muscles of our body. Deltoid muscle in our shoulder, biceps in our arm, quadriceps in our thigh, tibialis muscle in our leg. All of these muscle has origin where they start. Body, the bulk of the muscle where it contracts, or muscle belly, and where the muscle inserts right here. Pectoralis muscle started here at the sternum. That's the origin. And muscle belly is the flat area that works as contractile and relaxed component. That is where muscle contraction starts and ends. And it is insertion point is at the joint of this humor bone. Similarly, all muscle has origin, body, and insertion point. Tendons, connective tissue again. It attaches muscle to the bone. Muscle's insertion point is attached to the bone through tendon. Connective, flexible, fibrous tissue. Quadriceps muscle we see here attaches to the tibial muscle and the patella button through this tendon, patella tendon and quadriceps tendon, as an example of tendon. Now let's see, for orthopedic surgery, what type of diagnostic procedures are done? Mostly X-ray, anterior, posterior, and lateral views. That's the conventional X-ray technique. X-ray technique and fluoroscopy, which is movable real-time image, computerized tomography, which is CT scan, magnetic resonance imaging for MRI. These four are non-invasive diagnostic procedures. So they're not invading inside the body. Arthroscope, where an endoscope is inserted inside a joint to look at the joint, is invasive procedure. Since the scope is entering the body, it's an invasive procedure. So learn the difference between invasive and non-invasive. Simple distinction. Now, orthopedic surgery requires instrumentations. In two broad categories, we have exposing instruments like retractors, lots of many different designs. Exposing instruments. Then the grasping instrument to grab or grasp, to clamp the bone, to hold the bone. So bone holding forceps. Cutting instruments. We need to cut the bone using osteotome, gouges, chisel, curettes, ronger, reamer, bone cutting forceps, rasp, drill, saws. Just like carpentry, you use some of these instruments. We also have a majority of the cutting instruments, majority of this drilling instruments are power driven. Either gas powered or electric power, battery power instruments are used throughout the orthopedic procedure. Some of these blades, they cut by rotation, oscillation, and by going back and forth, proceeding blades. Then, obviously, in order to fix these fractures, you need rulers, calipers, and depth gauges to have a precision technique. Implant is a majority part of the orthopedic procedures. Implant related instruments would be something to drive that implants, a slap hammer to force that implant in or sometimes out of that bone, impactors to impact components at the end of the bone, extractors sometimes to extract the component from that joint. All of these are used when you're working and reconstructing bone joint with implant. When bone fragment is missing, then you need bone graft. Here, bone graft is being placed inside the joint where the bone is missing. Bone graft could be received or could be secured, obtained from the patient own body. That would be autograft. Bone graft could be allograft also, taken out from a other donor or cadaver. Usually autografts, bone graft, we take it from ilium. It's a cortical and cancellous bone, comes from iliac crest. And fibula sometime. Soft tissue bone grafts or soft tissue grafts like cartilage, ligament, and tendons also grafted from or received from the patient's own body and other patient's body or cadaver. So here is how iliac crest bone graft is taken. In this illustration, you can see autograft or autologous graft. Retractors placed, expose the iliac crest. Saw blade right here shows how the bone fragment is taken. Saw incised the bone all the way down, and this fragment is then taken. This is the bone graft that can be used for many different surgeries, like spine graft in between the vertebrae. So grafts are taken from iliac crest most of the time for spine surgery. Other supplies that you need for the orthopedic surgeries are fixation devices like plates and screws, rods, intramedullary rod that goes inside the cavity, intramedullary cavity, external supporting device, external fixator, internal supporting device, internal fixator, and implants, prosthetic implants. Some non-magnetic electrolytic inert material, stainless steel, cobalt, titanium, alloys, and polyethylene are the base of these type of prosthetic implants. They have to be non-magnetic, they have to be inert material, so they are not going to react to the body. Example of old style intramedullary rodding system called rush rod, used mostly in the late 60s and 70s. Rush rod is a kind of like this type of all-shaped rod that goes inside to fix the fracture of shoulder. Other supplies that and equipment that we need would include like PMMA, polymethyl methacrylate, stero bone cement. Usually it's called stero bone cement. Bone cement allows the implant to reinforce the reconstruction surgery or fixation. Cast and braces we use to immobilize the joint or the fractured fragment. Laser sometimes is used to repair cartilage. And laminar airflow system to provide ultra clean air system for orthopedic surgery. Here is what polymethyl methacrylate looks like. Usually, always you will have a mixing device like this or a different mixing device, but the basic is all same. You have a little container, a suctioning port, and a rotating stirrer on the top, and it is closed airtightly. What you put inside is this powder and the liquid. These two are monomers of the polymethyl methacrylate. When these two monomers are used, mixed together in here airtightly, it forms the polymer polymethyl methacrylate, and that is the base. Basically, we call bone cement. Bone cement can be filled inside the medullary cavity first. Then we use impactor to put the implant inside. This is the femoral implant or femoral shaft implant or femoral stem, what we call, now is implanted inside a cemented intramedullary cavity of femur. This reconstructed the hip joint. Cement sometimes is needed for certain implant, and we also have non-cemented implant where we don't need cement. We can simply impact that stem inside the medullary cavity, and we induce bone to grow and feel a tight bond. This is the bone cement injection gun. You feel this with the bone cement. It feels like a glue, white or blue glue. And then you use this pistol grip device to inject the bone cement inside the intramedullary cavity. Orthopedic fracture table, an indispensable equipment in order to fix fracture of hip. This fracture orthopedic table is needed for almost all cases of fractured hip. X-ray C-arm can be used with this type of orthopedic fracture table during the case, before the case, after the case, without violating the sterile field. That is the uniqueness of this orthopedic table. Let's look at how the patient is placed on this table. Here, this picture here, bottom left, you can see a patient is placed on that orthopedic table. Non-affected leg is abducted away from the body, secured on that leg holder. Affected leg is straight down at a normal anatomical position, placed on the ankle holder, a bar that is where the leg holding, ankle holding device is attached. Person is first fluoroed using this C-arm right here. The surgeon uses this C-arm right here. You can see it looks like C, that is why we call C-arm X-ray. Here, the surgeon required two C-arm X-ray, one from top to below, and another one from lateral to medial. Here, orthopedic surgeon is only using one C-arm, looking up and down, AP. Now, after the C-arm and the patient is placed on the orthopedic fracture table, surgeon will come under C-arm fluoroscopy, under live real-time imaging. Surgeon will reduce this fracture right here at the hip joint. Then he will clamp all of these here, here, here. There are clamps. He will clamp them to secure the leg in that reduced position. Then the circulating nurse will prep. Here we've shown betadine prep. Whole area where the incision will be made right here is prepped with betadine, all the way up to the umbilicus, groin, all the way up to the mid-cam. Then they will place a drape on it. We'll show you the drape in a minute. Drapes are placed on it, and then the orthopedic surgeon will, this case, it is shown external fixator is placed to fix this reduction of fracture. Most of the time, there are internal fixator that is placed inside to reduce the fracture. Orthopedic surgery is done for fracture of bone, reconstruction of joint, repair of tendon, ligaments, or arthritis or sport medicine injury. Wherever there is inflammation and problem in the joint and the bone, ligament, tendon, muscle, orthopedic surgeon does the surgery. Usually 6 P's are found when patient has orthopedic problem. Pallor, bluish coloration of their limb, lack of pulse. There will be lack of pulse at the extremity, paresthesia, tingling and numbness, swelling, and also paralysis, impaired limb function. When you see all these C's, all these conditions, when you see all of these conditions, then surgeon goes to further diagnosis of CT scan, arthroscopic exam, or MRI, and finds what is happening in this patient. X-rays been taken, and that is how the joints problem like fracture right here are detected, are diagnosed. And then the joint will be, that ankle joint will be fixed using many types of technique. There are many different types of fracture that we see in our patient. In children, we see green stick fracture and Colles fracture. These are like crack or little tiny fracture because of their bone is still growing and they're less stable, and sudden movement can cause this type of green stick fracture. Then we see orthopedic cancer, bone cancer, pathological disease of the bone, pathological fracture right here. We have longitudinal fracture, it goes up and down like this, like a spiral fracture, and longer spiral fracture is longitudinal fracture. Simple fracture, compound fracture, when the bone is broken and came out through a open skin wound. Comminuted fracture, when the fracture end of these two fragments of bone are crushed, fragments are missing. A gap of two fractured ends created, comminuted fracture. Transverse fracture, when cut a bone like this, vertical or horizontal, actually vertical cut, transverse cut. Oblique fracture. These are the especially many types of fracture that we deal with. Here are little better views, illustration of these type of fracture. Fracture can be managed or also can be detected as closed, like simple inside the wound. There's just a simple fracture, fragments, but it's contained inside the layers of the tissue. Open fracture, on the other hand, crushed and came out of the skin layers of the wound. And you can see distal part of the bone is here, exposed outside. This bone, this compound fracture, this distal part of the bone is exposed outside, means this bone is exposed to the bacteria, microbes outside. This could be an injury happened outside in the playground or the road, and this will be slightly or heavily infected. These people, the compound fracture people, need emergency open surgery. First, they will require to bring into the operating room from the emergency room. They will be washed thoroughly. This patient will have antibiotic running right away through IV. There will be used lots of saline, thousands of saline for washing this fracture compound site to get rid of the microbes. Then it will be prepped with very strong antimicrobial solution like betadine. Then they will be draped, and again, when the wound is opened, exposed, again the surgeon will have thousands of cc's of irrigation using a power washer called pulse lavage. They will use pulse lavage to clean further inside the joint to make sure all the microbes are washed away. They will debride some of this tissue here, which are already dead. So that is why this is called irrigation and debridement, IND, of the fracture site first. That is the first thing they do in this compound fracture. Then they will bring in X-ray, C-arm, and decide how to fix this fracture. Then they will decide technique to fix this fracture. Most of the time, this type of fractures are fixed with intramedullary rod, going a rod inside and hooking it, the fragments go back together, and that is how it is fixed. But the surgeon will decide how they're going to fix it. But compound fracture, when you are seeing a patient coming in, you need to have at least 10,000 cc of 10 liters of saline for irrigation, a pulse lavage system, which is a power washer, stereo power washer, and exposing both the fragment. You have to have a good retraction to see inside the joint. Pathological fractures are caused by bone disease, aging process or osteoporosis, normal looking bone here, cells are looking normal and everywhere. And here, osteoporotic cell, you see the cells are irregular, and the large irregular shaped cells, they are dead, making this area very, very weak. This deterioration can cause anywhere in the vertebra, in the hip joint, any joint. Osteoporotic bone right here, you see, looks like very loosely held structure. And here is normal looking bone with nice, strong scaffolder. So bone can be demineralized And also bone can have metastatic bone disease, cancer. When we see fracture, which is closed, not through the skin, and simple, they can be reduced or managed by close reduction and immobilization, like this. The surgeon will come, put the patient on this type of orthopedic table, bring in the x-ray, reduce this fracture wherever the fracture is located, and then put a traction ball here, and a pulley system will hold this leg, the fracture leg, on a traction. So this way, this leg will be immobilized. The patient won't be able to move it until the fracture is fixed, reduced, and fixed means fracture is managed properly. Union took place. That is when this traction will be taken off. Skeletal traction like this, you may find some patients are coming with this to your operating room. Why these patients are coming like that? They came to the emergency room maybe past midnight, and the surgeon came in to consult and found this patient has a hip fracture, but it's not required to be fixed at that time of that middle of the night. This patient can have elective surgery, scheduled surgery to fix the hip at a later time. But the fractured hip has to be on this type of skeletal traction to keep it immobilized, to prevent further damage of the bone. Keep it in alignment using this traction ball pulley system. So when they come into the OR, this is how the patient will come, and then the surgeon will have assistant holding the leg right in this same manner, same reduced, proper aligned manner, so there is no malalignment, and then take all these traction off for surgery. Then the patient will be prepped and draped, and the surgery will be done to permanently fix the fracture. External fixator is a good way and a very popular way to fix sudden fractures of the extremity and the pelvis also. And this type of fracture is reduced with this type of external fixator for multiple reasons. One, this bone will grow and fill in the gap of the fracture in about few weeks. Or the fractured area has a section of bone missing, requires traction to in place, immobilize in proper alignment, anatomical alignment, and use bone growth material bone graft to fuse the gap created by the fracture. Gap is so large that a plate cannot hold this bone together. So that is why internal fixation cannot be possible. So that is why they have to put this type of external fixator. This is Lizero, a titanium and stainless steel rings. They are placed for a multiple fractured, fragmented bone in this case. Tibia is shattered in multiple places. There is no bone fragments. There is a large amount of bone is missing. This type of people need external fixator. They will be on this external fixator and will be monitored daily by the surgeon. And when the surgeon will think the fracture healed, they will come back to the operating room and these external fixator will be removed. Then they will have normal dressing of the skin edges. Normal healing will take place. So external fixating device like this for this type of bad open fracture, multiple fractured site like here. It's done in the operating room. And they will have these rods and pins and half rods placed and will be dressed. Pelvis fracture, a lot of times in certain place is inaccessible because of the pelvic organs and the location. Those cases, this type of pelvic external device is placed and the patient is in bed rest for all of these cases. The patient will not move for at least 6 weeks. Pelvis fracture, sometimes months. Some of these fixations that you see the Lizero, they have multiple surgeries. They get fixed certain part and the Lizero is removed. They get bone graft, they get skin graft, muscle graft, tendon graft through multiple surgeries. So this is a very, very complicated fracture management process. You're going to see that in clinical, that fracture can be maintained internally also by putting plates and screws like this. This is when we call open reduction internal fixation. So this fracture site is opened by making incisions, by making arthrotomy of this ankle joint, exposed with retractors. Then the fragmented bones are aligned using bone clamps. Then plates and screws, which is underneath this top part, are here. Screws are here and the plates are in this box. It's called small fragment set. Synthes is one of the inventor for the small fragments back in the 70s in the Switzerland. Swiss Alps, lot of mountaineer and ski enthusiasts goes and they fracture multiple places in their body. That is one of the reasons the Synthes, one of the Swiss company, invented by few surgeons, this type of plating and screw system to manage to fix the fracture of those enthusiast snow athletes. But it is used throughout the world, and in United States we used it since 70s, and now the patented right is gone, so many other companies are making the same device, same screws under their company name. But this is small fragment set for ankle repair. We also have large fragment set for tibia, arm, like femur. So we have many different types of this type of internal plating and screw system that we use. But the technique is very simple here. Technique and the instruments are all on this part of the tray and this part of the tray. I will go through the technique in a second. So you're seeing internal fixation here. This plates and screws stays there until the healing takes place. Most of the time, it stays as a permanent internal fixation device. Sometimes, if the patient's having discomfort for the screws, long screw end, these screws may be removed. Another surgery. So instruments, bone plates, and screws you'll find in this type of fragment set. And this is how the surgery is done. That is bone plates placed here, bone plate clamps holding the plate, and the surgeon is inserting screws here. The technique for large fragment set, small fragment set, mini fragment set, all have the same technique. These are large for plates and large screws for larger bones. Now, the technique is this. The acronym, some of the orthopedic team has created called Don't Marry Too Soon. Drill for don't, D, measure for marry, tap for do, screw for soon. This is how some remember. But drill, measure, tap, screw is embedded in our memory if you are doing orthopedic surgery day in and day out. Most of this internal fixator screws use requires the surgeon to drill with their drill bit of choice, 3.2 millimeter diameter, or large drill bits of surgeon's choice, and depending on the orthopedic case, then they have to measure the drill hole, depth of the hole using the depth gauge. Then they have to tap to create the threads for the screw. Then they will actually insert the screw using screwdriver. AO means that synthese. It's a AO is a brand for screwdriver. This is how these screws are placed. The screw head has this type of head, AO head. So here you are seeing drilling is going on. Drill bit with a chucks, Jacob's chuck, and power drill. And this is the drill sleeve or soft tissue protector. Drill bit is going on. Next thing they will do, they will measure the depth. This is the drilling part, drill bit and drill guides. Next part is depth gauge measuring using the depth gauge. Then make the holes, the screw holes using the tab, and using this AO screwdriver, you put these type of screws in. These are cortical screws for hard bone, compact bone, like this here. These are canceller screws, where the screw, these threads are separated for soft bone. These are half-threaded canceller screws, where threads are to the end of the screw, other half is a gap there to allow the bone to reduce, and these are partially threaded canceller screws, where the threads are almost to the tip and there's a little gap there. These are designed such a way to reduce the fracture when the screw is inserted properly. Here, are some examples of cancellous and cortical screws. Cortical screws here, cancellous screws this one and this one. You can see the difference in the thread. Also, we have nailing device like intramedullary nail that you see here. Fracture is managed through the nail, through the intermedullary cavity, and distal screws, proximal screws. Proximal screws here going through all the way, distal screws here, managing the hip fracture. That's another way you can manage the fracture using intermedullary rod, or you can use external, like plating, internal plating, but not going through the cavity, but the plate will sit outside edge of the bone. There would be a screw, barrel screw, we call intratrochanteric fracture, like this fracture, which is happening in between the trochanteric line, separating the head of the femur from the distal part of the femur. This type of fracture can be popularly managed with this type of hip compression screws. This screws, the barrel screws that you see, is larger in diameter, 6.3 to 7.5 diameter. Larger screws hold this plate and the barrel to manage this type of fracture. Then the shaft of the femur, we have these screws that keep the plates attached to the shaft of the femur. This is the barrel plate when you are taking it out from the plate tray. There are many names for it. MB is DHS. There are many different types, technique, but baseline, the fundamental thing is all they're doing this type of fracture management. Having shaft screws, barrel up the plate, and compression screws going down all the way up to the femoral head. You have a tray which will have plate, all of these components that you get it from the cart, which will have all these stereo components. The measuring and the trial will be inside your tray. The surgeon will trial that with the trial device, and then will tell what type of plate and what measured screws they're going to use, and the circulator open these plates and screws for you from a stereo implant card. There is the intermedullary rod going down and the proximal device fixing this femoral head. Fracture here, fracture in the intertrochanter, fracture the neck, all can be managed like this, intermedullary rodding. Here is the titanium rod and screws, what they look like. And this is the X-ray of those, what they look like after the fracture is reduced. Groskamp, Brooker-Willis, Russell Taylor, Smith nephew, there are many names to it, but they all kind of do the same action, same function to manage the femur fracture. These are some of the equipment that stimulates osteoblastic growth, means bone to regrow. Joint procedures are done in order to fix the joint injury, arthritis, and degenerative